Why is medicine's reconciliation important to the patient, and what is the risk to the patient if we get it wrong?
I think it's very important that patients know, firstly, the medications that they're taking, and secondly, the reasons that they're taking those medications. If, for whatever reason, they are taking medications that they shouldn't be, then they may come to harm. They may end up back in hospital for a drug-related incident, or in some serious instances, it could potentially cause a fatal outcome. I recently had a patient who was admitted with a head injury to a surgical ward, and he was on warfarin for atrial fibrillation. When he was in hospital, the warfarin was discontinued. It was recorded on his immediate discharge letter, but the patient himself either hadn't been told to stop his warfarin or had forgotten, because he was in hospital with a head injury. When he came home, he continued to take his warfarin, unbeknown to me, until he came in one day and asked me why he wasn't getting any more blood tests. So I was aghast at this and followed the process backwards and figured that for some reason he was still taking the warfarin. Now, he was fortunate in that he didn't come to any harm, but the process of communication had broken down somewhere with that patient.
Do you feel that the work as part of the patient safety programme may reduce the risks that you've talked about?
I think so. We've been doing it for several months in practice, and certainly our repeat prescribing system for those patients that we've had medicines reconciliation done with has improved, so that it reflects a much more accurate recording of the medications that they should be taking, whereas before we weren't quite sure what was happening, and if we weren't sure, then certainly the patient wouldn't be sure either. So from that point of view, it certainly has benefited the patient. Very
good. One of the elements of the work is around discussing the medication changes with the patient. What do you see as the benefits to this?
Well, certainly from the point of view of patients being empowered to A, know the medications that they're taking, and B, the reasons for it, I think is very important. Equally, it's not just the patients, because quite often the patients that we're dealing with are elderly. They may be in residential homes, so it's important that we're also discussing changes of medication with the family or carers, and that increases the communication between everybody involved in the care of that patient.
So you would say then that this has improved communication between you as a GP and the patients generally?
Yes, and the whole team of people who are involved with that patient, whether it's the relatives, the local pharmacies, or the people who call in to check on them on a day-to-day basis.
As one of the participating practices, you have agreed to implement the Medicines Reconciliation Bundle. When this local enhanced service ends, would you see any further opportunities to improve the patient experience?
Well, it would be our plan and hope to continue the Medicines Reconciliation as has been proposed and that we've been carrying out, because we do see the benefit of it. It has to be said that it is time consuming for one person to do the whole medicines reconciliation from start to finish. So rather than having each individual doctor or nurse in the practice involved with it, it would be our thinking that we should maybe have just one person who is dedicated to checking the immediate discharge documents in relation to discharge medications with the most appropriate person. Now, that may be with the patient by a phone call, maybe with the pharmacist, maybe with the family, or it may be that that dedicated person would suggest that the doctor would visit to check on medications, or indeed ask one of the district nurses if they would be willing to do a similar task. But to avoid overcomplicating the process, we would envisage maybe a small limited team within the practice who would be experts in that area.
Thank you very much, Dr. Kemp.
Okay.